The topic of our lecture today is ward rounds and documentation. Throughout this topic, we will cover the importance of good documentation, how to document during a senior-led ward round, how to document during a solo ward round, and a jobs list. So if you have any questions, feel free to put them in the chat box. Unfortunately, I won't be able to see the chat box at the moment, but after the lecture, I would be happy to answer any questions you do have. So what's the purpose of good documentation? Documentation of patient notes is a legal document, so that's why it's important to write it legibly, and it should not leave the hospital. So it's a legal document where anything that's written in it can be used to look back when doing, for instance, internal investigations into patient's death, or just evaluating patient's care, or doing some audits. It's also important to document well to ensure good patient continuity, so good patient care. For instance, if you're the doctor seeing a patient on one of the days, and on the following day you're not here, your colleagues will know the plan and what has been done through good documentation. Good documentation also allows for good patient care within the multidisciplinary team. For instance, the nursing staff know what the plans are for a patient, or the physiotherapist and occupational therapy are aware of a patient's planned expected discharge date, and that can help in facilitating a patient's discharge. Good documentation is also important in writing discharge summaries. For instance, if you are the doctor asked to write a discharge summary whilst you're on call for a patient you don't know about, you can look through the patient notes, and it's through good documentation that you get to know about the patient and the treatment they have received in hospital. And this will help you write a good discharge summary. And another reason for documenting well is that you can update patient and family members of a patient's care. So then when looking back, you know what's been done for the patient and the plan going forward. Remember, if you don't write it, it never happened. That's why it's always important to document every little thing you do. So here are the basics of good documentation. First and foremost, it's important to put the date and time and have the patient identifiable details. Most hospitals using paper notes will have patient stickers with the NHS number and date of birth. For those of you working in hospitals with electronic patient records, the date and time and the patient identifiable details will already be there. When documenting, it's important at the top to put your name and your role as well, along with any other person who you were with who have seen this patient. It's also important to include a plan of what you were thinking and how the treatment should go forward. And on finishing your documentation, you should finish it by writing your name, your GMC number, and signing it as well. Good documentation should be legible. So think of your other colleagues. How will they understand something and understand the patient's care if it's not legible? And it's important to be polite in documenting and courteous as well, because, for instance, some patients might be able to request their patient notes in the future. So here are two examples of documentation which I have done. They're for fictitious patients, but just to give you a broad understanding of how to document as a Foundation Year 1 doctor. On the left-hand side, you have the date and the time. That's important to know at what time you saw this patient. And on top here, you have the patient identifiable details. Or as I said, in some hospitals, you can have a sticker which can replace that. On the top, I have my name and my role as well. And that could be your role as an FY1, or it could also be as your role as an on-call doctor. For instance, I was on call. So this just goes to show that I don't usually look after this patient on my normal day-to-day job, and I'm just covering out of hours. And for this instance, I've been asked to review the position of the NG tube as confirmed by a chest X-ray. So as you can imagine, it's really important that I document this, because nurses would not want to start NG feeding unless it has been documented that the NG tube is in place. And I've also written a plan with my documentation as well. On finishing my documentation, I have signed it with my name and my GMC number as well. Most of you will get a stamp on starting as a foundation year doctor, which will come in quite handy when documenting. On the right-hand side is another example of documentation where I have been asked to see a patient who has had a head injury. So again, I have the date and the time on the left-hand side, my role and my name, along with the reason why I've been asked to see this patient. So this gives my colleagues an understanding of why I'm documenting in this patient's notes and why I'm reviewing this patient. And in here, I've written the results of any investigations which I have done or which I have found. And again, written a plan and signed it with my name, GMC number, and a signature. So now I'll go on to touch on briefly of how to document during a senior-led ward run. So the majority of your ward runs you will do as a foundation year 1 doctor or senior-led. So that's either with a consultant or registrar. When documenting for a senior-led ward run, it's important you have a patient list or jobs list next to you that can come in quite handy so you can write jobs along the way and you can refer to later after the ward run. Again, at the top, you should write the date and the time, along with the name and the role of the senior colleague who's leading the ward run. You can also write your name and your role next to that. It's important to prepare observations for the patient, including their news score and any blood tests and the results and the trend of the blood tests as well. It can be quite relevant to include medications patients are on. For instance, if a patient is being treated for sepsis and writing which type of antibiotic they're on and which day of the course of the antibiotic they're currently on, and any results of scans or procedures. This will give any doctor or any healthcare professional a general understanding of the patient when they read your documentation. So it provides a good summary as well. When you're going to see the patient by the bedside, you can write any observations you see of how the patient is doing. For instance, some colleagues may write patient is comfortable at rest if they are, or they might choose to write patient is short of breath or any signs or symptoms the patient complains about. It's also important to write any relevant examination findings during the ward round, as this can give an indication of any diagnosis, and to have a plan as instructed by the senior person leading the ward round, so you can refer to for the future when doing jobs for this patient. So again, I've provided examples of documenting for a senior-led ward run. So that's just my style of documenting. When starting as a foundation year 1 doctor, you will each develop your own style of documenting, but here's just a general style to go about. Again, you have the date and the time on the left-hand side, the patient details on the right, including their name and their NHS number or their hospital number. And on the top, I've written the name of the senior person leading this ward run. In this instance, it's a consultant. Just to iterate that all the details in this are fictitious and they're only being done to provide an example. On the left-hand side, I like to write the patient's observations, including their news score and for what they're scoring. And on the right-hand side, I also like to write the patient's blood test and the trend of the blood test. So when checking the trend of the blood test, you can see, for instance, if the inflammatory markers are increasing or decreasing. So this, for instance, is the results of the blood test done on the 5th of June. And on the right-hand side, although I've not written the date, are the blood tests of the previous results. So you can see the white cell count is falling along with the neutrophil count. On the top, I've given a brief history of this patient, a brief summary. For instance, this is a 60-year-old male with a background of heart failure, type 2 diabetes, and osteoarthritis. You might notice that I'm using a lot of abbreviations. That's because whilst documenting during a ward round, time is limited, and you will become familiar with common abbreviations you can use. I've written here that this 60-year-old gentleman presented with a 2-week history of worsening shortness of breath and ankle swelling. And this little triangle symbol is commonly used amongst doctors, which means the diagnosis for this patient. So CCF is congestive cardiac failure. They also have a UTI, a urinary tract infection, and an AKI stage 1, which has been resolved. Below, I have gone on to document the treatment this patient is currently receiving. For instance, this patient with heart failure is currently being offloaded with IV furosemide twice daily, and they're on a day 3 of a 7-day course of trimethoprim for their urinary tract infection. I've also included the results of any relevant investigations. For instance, the chest X-ray is clear, and an echocardiography has showed a left ventricular ejection fraction of less than 40%. As I mentioned earlier, these are the bits we prepare before going to see the patient. And by the bedside, you can record any observations you have seen. For instance, the patient was comfortable at rest and they had no new concerns to report when asked. When documenting examination findings, you can also make little drawings. For instance, you can draw 2 triangles to represent the chest and the lung fields. Heart sounds are usually documented as 1+2, and if you do hear any additional heart sounds, you would document them on there. The abdomen sign is usually documented with this little symbol here, and if you do cross it out, it means that there are no relevant findings and that it's normal. And here I've just drawn 2 legs to show evidence of pitting edema. To continue on my documentation, I've written a plan for this patient. So they're to continue offloading, they're to have their weights taken daily, and to have blood tests taken every other day, and to continue on their antibiotics for their urinary tract infection. I've also written a plan if this patient has a further spike in temperature, blood cultures need to be taken, and the case needs to be discussed with microbiology. And other plan for this patient is to get the notes from another hospital and to start discharge planning for this patient. As you can see, this is a very comprehensive plan. And if my colleague who was not here when we saw this patient on that day comes in the next day and is to take over the patient's care, they can have a good idea of what we're planning for this patient. As you can see from the temperature spike as well, if any other doctor is on call, they can follow the plan of what to do if the patient has a temperature spike. So that's why it's important to document well to ensure good continuity of patient care. And so your colleagues can continue on from the treatment you've given off for this patient. I'll briefly touch on some common abbreviations you might see as a doctor. Just a side note, these are only a few examples, and you may come across more whilst working as a junior doctor. And ABX is usually used for antibiotics. And this concept of time took me some time to come through it. So usually if you're writing 1 out of 7, it's because there's 7 days in a week. So 1 out of 7 means 1 day. 1 out of 52, because there are 52 weeks in a year. 1 out of 52 means 1 week. And 1 out of 12, because there are 12 months in a year, means 1 month. BMs are commonly used to indicate blood sugar levels. NBM means nil by mouth. HR is heart rate. RR is respiratory rate. MFFD is medically fit for discharge. So that means this patient has completed all their medical treatment and usually, and they can go home, usually pending arrangement of facilities at home or package of care. PT and OT are physiotherapy and occupational therapy. TWOC means trial without catheter. That means removal of a catheter and seeing if the patient passes urine. FU is follow-up. R/V is review. And POC is package of care. So package of care is usually when a patient is fit to be discharged from hospital and they just need to be discharged into the community with additional support in place. And usually if you see a question mark, it means query of a suspected diagnosis. The next part is documenting for a solo-led ward round. That means when you're about to see a patient on your own. Although the instances of this happening might be few, near the end of your FY1 post, you would be expected to see patients on your own sometimes. Although don't worry, the senior people who have seen this patient before will usually have a good comprehensive plan in place to follow. So it's important before documenting for a solo ward round to prepare well and know your patient well. Familiarize yourself with the previous plan and the current management. So these are usually the plan made by senior consultants or registrars who've seen this patient the day before, and follow their current management plan. As I mentioned earlier, it's important to check the patient's observation, including their news score. For most of you, the news score will be available on the computers, but for some of you, it might be available on paper notes. And to check the blood test and the trend of the blood test, which could point you towards a diagnosis. When doing a solo-led ward round, it's important to update the patient of their blood test, their scan results, and where their treatment is, and the expected discharge date. If you're not sure of this, you can always consult with the seniors and get back to the patient. It's quite important to keep the patient in the loop of their treatment. When doing a solo-led ward round, it's also important to examine the patient systematically to check for the improvement of symptoms and just to screen for any evidence of new infection which might have been missed before. Always discuss the results with a senior, that might be your registrar or a consultant. And have a low threshold to escalate. So if you're worried about the patient, always escalate to a senior member of staff. Remember, there's always support available around, and you're never on your own. The next part of this lecture will briefly touch on the creation of a jobs list. The jobs list is one of the most important things you can create every day as a junior doctor, because it's the go-to piece of document where you can use to do jobs throughout the day. You might have the patient details, including their location. So, for instance, the bay the patient is in, their name, and a quick diagnosis, just to remind yourself of what this patient is being treated for. Any ongoing issues. And next to it, you write any jobs that you need to do for this patient throughout the day. For instance, if you need to contact microbiology, do blood tests for this patient, update their family, write a discharge summary, or any blood test or any job you can think about. It's important you write it on your jobs list so you don't forget. And usually it's important you write it on your jobs list as you go around during the ward round seeing the patient. Regroup after the ward round and go through the jobs list with your other colleagues to check that you've not missed on any jobs. And go back to the notes if necessary to check that the plan correlates with the jobs list. And then divide the jobs between yourself as junior doctors to complete the jobs by the end of the day. If there are any outstanding jobs that are important, you can always hand over to the on-call doctor or to the night doctor, for instance, if you're about to finish your shift. And if there are any jobs that are not important and haven't been done, you can always re-refer to it on the following day and try to do these jobs if you have time on the following day. This is a common symbol used by junior doctors when creating a jobs list. For instance, you can draw a little triangle, and if the triangle is not shaded in, it means that the job is outstanding, so it still needs to be done. If you draw one line through the job, it means part of it has been done. For instance, if you have requested an X-ray scan, but it has not happened yet, you can draw a stripe through line through it. When you shade half of the triangle, it means half of the job has been done. For instance, if the job is to take bloods for a patient, you can shade half of it if you've taken the bloods but are waiting for the results. And you can shade this rectangle completely if you've completed the job. To summarize this lecture, I've gone on to explain the importance of good documentation, how to document during solo and senior-led ward rounds, and how to write ward round entries. I've also briefly touched on the importance of a jobs list. Thank you for listening to my presentation. I would be grateful if you could please fill out the feedback form by scanning this QR code, and feel free to put in any questions in the chat box, which I'll go on to answer shortly. Thank you. Okay, so I'll be happy to take any questions you guys have if you just put them in the chat box. So Andrew has asked, do trusts that are completely electronic have their own version for symbols or drawings? No, unfortunately, those that have electronic notes won't have symbols, so you'll just need to type them along. Is it common to have a jobs list on the ward computer that all doctors keep updated for the purpose of handover? So in my experience, jobs lists are not on the computer. It's something that you need to write down by hand, even in those trusts where everything is electronic, because your jobs list is for you. It's a personal jobs list. And don't forget to dispose of your jobs list at the end of the day, because it can contain confidential information. So dispose of it by throwing it in the confidential waste bin. I'll put the link for the feedback form just there. This lecture is also being recorded and will be available to watch on Mind the Bleep's YouTube channel as well. So Hassan has asked, what do you mean by putting off jobs for the next day? So sometimes you'll have loads of jobs for a patient and there might not be enough junior doctors on the ward. So in that instance, if there are less urgent jobs to do, you can schedule them for the next day. Common examples I can think of are preparing a discharge summary. So if you know the patient is not going home today, but you're anticipating they might go home later on that week, and you need to prepare the discharge summary, and you're busy on that day, you don't need to do it immediately. You can do it whenever you have time. Do you guys have any more questions? Just to briefly share with you an important resource for incoming Foundation Year 1 doctors. At Mind the Bleep, we've created a survival guide booklet, which you can find online. I'm just going to share it now so you guys can have a quick look of what it looks like. So this is the FY1 survival guide, which is being created by Mind the Bleep. It's being created by a team of doctors, including myself, and it has important information about things you might need as a Foundation Year 1 doctor. For instance, it covers the role of the multidisciplinary team, your role as an FY1. We have links to other resources for Mind the Bleep, how to document as well. There are further examples in there of how to document. Medication tips, common medications you will be expected to prescribe as a Foundation Year 1 doctor. The priority of the job, how to prioritize jobs. So jobs which are more important to do and those that are less important to do. Writing discharge letters, an example of a discharge summary. We also have information about common resources that are useful for a Foundation Year 1 doctor. Apps you can download on your phone, joining the BMA and the MDU. And important information about your payslip, for instance, your gross pay, tax, taking out student loans, keeping a credit score, and a breakdown of different leaves you can take, including annual leave, study leave, sick days, and other relevant information. So to get access to this, you can Google the Mind the Bleep website, and check out for the FY1 survival guide booklet. So I'm just going to answer a few more questions we've had that have come up. When you're making notes for a new patient on the ward using the ED report, I'm not quite sure of the question, Richard. When you showed the notes for senior-led ward run, was that what you wrote down in the patient records, or is it something personal for yourself? So to answer the question about the example I showed for a senior-led ward run, that's an example of something I've written for the patient's notes. Usually, you won't actually have time to document personal notes for yourself in that much detail. But when you're writing in the patient's notes, it's important to include as much detail as you can. And that was just a good example of documentation during a ward run. As you guys will be starting and rotating through different specialities of foundation training, you'll see that your style of documentation will change. For instance, whilst working in surgery, you'll have less time to document in that much detail. So your documentation will be very brief. But it's always important to remember to document the important things. If you do procedures, examples as cannula, does that need to be documented too? So that depends on the person. For instance, I usually don't document if I've done a cannula, but I know of colleagues who do document. It will also depend on your trust protocol. For instance, some trusts ask that you include the cannula stickers and the date and time of insertion of the cannula, so the nurses can check the VIP score and to remove the cannula after it has expired. But in general, little things that you don't need to document include prescribing simple analgesia for patients such as paracetamol, inserting cannulas, doing bloods. You don't need to document those. Things that you do need to document include any discussion with any other specialities such as microbiology or radiology, any results, or doing any procedures such as blood cultures or insertion of a catheter, because this will allow you to know when those procedures were done. And for instance, a catheter, you can then know the indication for insertion of a catheter and when the catheter needs to be removed. So Marie has asked how to access the survival guide. So if you join on the Mind the Bleed page, I'll just see if I can find the link for it. You just type in Mind the Bleed FY1 survival guide. There's a link on there, and you need to register with your email address. So registering with that, you'll sign up for Mind the Bleed webinars and weekly tips. But if you're not too interested about that, you can just sign up to get the survival guide and then unsubscribe. I put the link down below for the Mind the Bleed page where you can find the survival guide. Okay, Pietro has asked, so does that mean every morning when a senior reviews the patient, you document in that much detail if possible? Yeah, so ideally you would want to document in that much detail. Usually you won't be alone on the ward, there will be a team of you of usually 3 or 4 junior doctors. Maybe you'll be expected to look after 5 to 6 patients on your own. So that's why it's important maybe to come in a little bit earlier or than your senior does. So for instance, as a foundation year 1 doctor, I would usually come in 10 to 15 minutes before and briefly prepare the notes. When making notes for a new patient on the ward and using the ED report, is the structure for making the notes similar to the structure that you recommend in the slides, or are there any additional points needed? So to answer this question, Richard, about clerking in new ED patients, most hospitals will have a clerking pro forma, both in the emergency department or in the AMU, acute medical unit, follow this clerking pro forma. However, some hospitals, the pro forma is quite vague. in that instance, I would follow that example I've given. But as I've said, this is just my example of documenting. You will develop your own style as you start working as a junior doctor. Do we have any more questions from the audience? You have to document if a scan referral has been rejected. Yeah. So it's more important, Tari, to document that a scan has been rejected rather than a scan has been accepted. Because if you document that a scan has been rejected, you can write the name of whoever rejected the scan, and then like whoever is also looking after this patient can re-request the scan or will know why the scan hasn't been done. For instance, if the plan for a patient is to get a CT scan, and you as the Foundation Year 1 doctor have gone to request a CT scan and it got rejected, the next day when the consultant comes along and the CT scan hasn't happened, they won't know why the CT scan hasn't happened. They might expect the scan to take place later on this week without knowing that it has been rejected. So that has happened a few times in my hospital where there's been evidence of poor documentation and where we've thought that the patient was expecting a scan for almost a few weeks when in actual fact the scan has been rejected and there was no plan to do a scan at all. So that just delays patient care. And as you can imagine, it can be quite detrimental to the patient as well. Do we have more questions from the audience? I know there might be a lot of anxiety amongst you guys so starting as a Foundation Year 1 doctor. However, it's important to remember that we've all been through this process and you will learn through the job. It will be like you'll learn a lot within your first week as working as a Foundation Year 1 doctor, and it'll all become second nature to you once you get on the wards. So as I said, there's always support available from your senior colleagues, which include FY2s up to consultant levels, and everyone is quite nice. No one will refuse to help you. So always, if in doubt, consult with your seniors and ask for help. So it seems there are no more questions at the moment. For those of you who have tuned in, be sure to keep an eye out for our future webinars. We'll have other webinars on prescribing, so common prescriptions you can be expected to do as a Foundation Year 1 doctor. We're also expecting to have webinars on common presentations you can have working in the medical or surgical department, so that will depend on whichever rotation you're starting on first, and covering managing money matters as a Foundation Year 1 doctor, because it can be quite overwhelming starting a new job with this new salary and not knowing how to budget or how to save. So we have different people from the Mind the Bleep team contributing to this webinar series, and we'll be posting regular updates on Facebook. It seems at the moment there are no further questions, so I'll let you guys go enjoy the rest of the day, and thank you for tuning in to this webinar. Best of luck with starting Foundation Year 1.